our results suggest that RA patients show detectable patterns of care use. And for clinicians, when a patient shows up in their office and has a diagnosis, often one of the first questions I feel like I've heard from patients is, what does this mean for my life, and what going forward can I expect? And the nice thing about these results is it really gives physicians the data to say to patients, here are the different systemic risks of RA. You can expect a certain increase in heart conditions, lung conditions, and they can give those percentage risks to patients. And they can tell them that, well, they can confidently say that this diagnosis period is likely the worst for comorbidities that they're going to have, and it will likely get better. So they can not only talk about long-term disease trajectories with the patient, but they can also discuss the disease-specific risk conferred by this diagnosis. Not to scare patients, but just to give them a realistic idea of what the disease is actually going to be like. So we detected the differences in comorbidities with a large database and the collection of many data sources together. So we used hundreds of thousands of observations, but clinicians and patients dealing with an individual case may only see a small portion of the medical resources used, and they don't have access to this kind of large hundreds of thousands of person sample to directly make predictions or make care decisions with. However, our results do suggest the possibility of a patient or clinician to pick up the early telltale signs of RA or be on alert for these symptoms. So in the future, clinicians and patients who have a high probability of RA, given the past medical history, we could be using computer predictive tools to actually alert a patient or give a recommendation based on a patient's risk profile that could tell a patient that they're more at risk for certain types of comorbidities or negative events. So I would say we have to walk before we run. The first step was to define the disease, but as time goes on and as our technology gets better, we should be able to move into more assisted decision-making for patients and clinicians with this disease. I don't think that's out of the realm of possibility. I wouldn't call it fanciful. I would say that our results do suggest there is data to say, at least at the population level, that predictions could be made about a patient's future risk of acquiring RA. And if those predictions were possible, medical ethics dictates that you should at least ask a patient if they would like to know about this increased likelihood of a disease. So today we don't have those predictive engines to do that, but I do think it's certainly possible to create something that would do that, and I do believe it would provide utility for patients, and that if such a prediction could exist, that patients would want to know about it, and there would be utility in telling them about this kind of increased risk. Now, again, there may be uncertainty in this prediction, but I think that in patients who have a risk of developing a chronic condition, just to know to look for the symptoms could help with early treatment or with early disease recognition, improving outcomes for the long term.